All right, let's go ahead and get started. So, this PowerPoint is going to be pretty much over hypertension medications. And the reason that I'm doing this is that despite the fact that I'm sure that this is covered in your theory, you may have listened to your theory about this section about these medications and pretty much been like, "Ugh, like, and felt like you had hypertension after reading about all the medications that you have to know. And I'll have to warn you that there is going to be more. Sometimes when looking at these, they seem like there's so many of them. But if you can kind of group them or categorize them in a different way, a lot of times they'll help kind of break it down and make it a little bit more simple for you so that it doesn't seem so dang overwhelming. So first we need to start with why do we, or not why, but what do we need to treat hypertension? So when we're talking about hypertension, we're talking about high blood pressure. There's too much blood pressure, in the body, which can lead to a lot of consequences. What we need to treat hypertension, we always want to think about, we need to do something to decrease the amount of volume that's in the blood, and then also the amount of resistance, constriction, or narrowing. So, in other words, kind of think of your blood vessels when you have high blood pressure. It's not, sometimes they are just full of fluid and they're really big and full of fluid, but a lot of the times with high blood pressure, they're actually really narrow. So, think of a really tiny funnel that all of your blood is trying to get pushed through. And so, there's so much pressure because these vessels are so narrow. So, the two things that we can do to kind of help with this, and this is going to help guide us in understanding these medications. If my blood pressure is high and I need it to be lower, less pressure, one thing I can do is remove some of the fluid. If there's too much excess fluid, kind of fueling that, then I can take some medications that can help me to get that extra fluid off. That's used sometimes. More commonly, what I do is I give medications that are going to help to, I told you it's like a narrow funnel that the blood is being pushed through. And there's a lot of medications that can help with that narrowing. So I have a more wide open funnel instead of a tiny little funnel, I get a very wide open funnel that can help to make it easier for blood to flow. Because at the end of the day, the goal here is that I have better blood flow to my organs. Because one of the things I brought up in my own, theory is that the fact that, a lot of people think high blood pressure means you have a lot of really good blood flow. Like high blood pressure, at least I got blood flow going to my organs and stuff like that. But that's actually not true. A lot of times the pressure is not actually a good flow. There's just a lot of pressure because everything's really narrow. So it's kind of like trying to pour like a jug of milk into a really tiny funnel. No matter how much volume, everything else you have, if it's a really tiny tube that you're trying to push it through, there's too much pressure. So some of the ways that we can kind of use medications to do this is we can give medications that are going to stop the body from being in the fight or flight, life or death kind of, mode where it's just going. And that can help to decrease some of that narrowing or constriction. We can also yeah, work to oppose what's called the RAS or the renin angiotensin aldosterone system. And that's a system in the kidneys that, kind of fights to hold on to more sodium and water. And it also makes your vessels really narrow. So that can kind of help in both ways. And then we can also, stop the blood vessels from contracting so much by messing with things like calcium and stuff like that. And we're going to go in depth about each of these, but I just want to kind of give you a picture. If you're ever looking at these meds, instead of seeing them as just like a name of a medication and stuff like that, try to think of them as what do you call it, how they're going to help that patient. Like, really think about how, like, what are you expecting to happen in the body because of this. And I don't mean the deep patho, but I'm talking about just thinking on a basic level. If my patient has high pressure in their blood vessels, what is this going to do for them? Is it going to decrease their fluid? Is it going to stop them from being so narrow? Is it going to stop one of their systems, that's kind of fighting to cause it to be so narrow? How is it going to help? So let's get into this. So let's start with diuretics. So diuretics help patients with high blood pressure because they help by decreasing the amount of fluid. If there's less fluid, like I mentioned, there's less pressure because fluid is pressure. I have to have fluid in my blood vessels to have pressure. And there's, two types. Well, there's four classes, but there's two main types of diuretics. There's those that lower potassium, and those are the thiazide or the loop diuretics. And then there's those that increase potassium, and that's the potassium sparing, and then also the aldosterone receptor blockers. So let's break these down. So let's talk about potassium wasting diuretics. So these are the ones that get rid of not only just water, but they also get rid of potassium. And so with these patients, okay, if I'm getting rid of water, great, my blood pressure is better. But if I'm getting rid of potassium too, and by the way, I'm like getting rid of potassium, like when we give this for high blood pressure, we're not trying to get rid of potassium, but it's a side effect of the fact that the way that these medications work is they get rid of water, but they also get rid of potassium at the same time. So, with these patients, if I'm getting rid of water, but also potassium, while I want the water to be gone, I don't want to lose the potassium. So I'm going to need to tell these patients, hey, you need to eat more potassium rich foods. And we're going to talk about those near the end, and about some of that more specific teaching. But when I'm talking about potassium wasting, or they're wasting potassium, getting rid of potassium, I'm talking about loop diuretics, and I'm also talking about thiazide diuretics. And so for these types, and most people most commonly know like loop diuretics like furosemide, you want to keep in mind that all of them are going to end in the MIDE, NIDE, or zone. So any potassium wasting diuretic, all of them are going to have MIDE, NIDE, or zone in them. And so I have that little rhyme, and I do have mnemonics on my Google Drive if you want to look deeper into these. The MIDE, NIDE zone, no potassium will be home. And so kind of remember it that way. One other more specific thing to remember about furosemide is that if you push it IV push and push it too fast, they can have ototoxicity where they actually lose their hearing. They'll complain of having like ringing in their ears, and they can easily lose the, not easily, I don't want to say easily. It's not something that happens all the time. I don't want you all to be paranoid now when you're giving furosemide, but if you do push it super fast, it can lead to that ototoxicity. So we want to make sure to push it over at least 2 minutes, and take our time with that. We also, for potassium, on the other end of the spectrum, we have potassium sparing diuretics. So we had potassium wasting, getting rid of potassium. Now we have potassium sparing. In other words, it's going to spare the life of potassium. It's going to save it. So this medication, it gets rid of the extra water and it saves potassium. So this might seem great. It's like, well, why don't we just use this? Well, these ones don't work as well as the potassium wasting diuretics. And with them, there's a lot of concerns about the fact that they can actually raise your potassium. And while having potassium at all seems better than having like less potassium, if you have too much, then you can have a problem either way. Too little or too much potassium is always going to be a problem. You want it to keep it in that normal range. And so for potassium sparing diuretics, for ones that we hold on to the potassium, we're going to have to be really, really careful, that they're not taking in too much potassium. So they may need to decrease their potassium intake, or at least, if nothing else, avoid things that are going to increase potassium. So in other words, they're going to probably need to, we're going to talk about some of the specific things they need to avoid, but they're going to need to avoid any other medications, foods or things like that that are going to cause increasing potassium, because as a whole, I'm already holding on to. Think of someone who's kind of like a hoarder. This is like the potassium hoarding diuretic. So they're hoarding potassium, they're holding on to it. So if I'm holding on to potassium, then I'm going to be worried about anything else that I'm already doing that's going to like synergistically do that, as well. And then I have just like too much potassium. Think of like two hoarders who got married and they're all saving the same thing and they have too much of it. You can kind of remember this one. The big one in this class that you see commonly given is called spironolactone. So judging by your tone, your potassium must have grown. So that's a little mnemonic for you. So some teaching for all diuretics. These medications decrease volume and fluid, which means less pressures, which means I need to check the patient's blood pressure prior. Now you're not going to see this done by most nurses because most nurses don't think about, hey, I'm giving this diuretic and it's going to decrease the patient's blood pressure, because a lot of times diuretics can be given for other reasons. We're going to talk about how it's given for heart failure too, but checking a blood pressure is always a very important thing to do, because their blood pressure can significantly decrease after taking this medication. And because of that, they can also have some of that orthostasis. So we want to tell them to change position slowly. So these medications will make the patient pee. So we always want to consider that for all types of diuretics, safety is going to be an issue. So this patient's going to have to go to the bathroom frequently, and they're going to need to have a safe environment. The other thing to keep in mind is that a lot of times these medications, like taking them at the right time. So we want to encourage people to take their diuretics in the morning. And if you think about why that makes sense, like, if I'm taking a medication that I have to pee a whole lot with, I don't want to be getting up in the middle of the night 20 times to have to pee, especially if safety is an issue. Because at night, everything's dark. I might trip on something like that. So I want to tell the patients to take this in the morning. That way that they're not staying up all night peeing and that they can, safely get to and from the bathroom with the proper lighting. For all types of diuretics, I need to monitor their potassium levels, whether it's going low or high. Something's happening to my potassium with all diuretics, so I'm going to need to watch that closely. And I also need to monitor kidney function. All diuretics are hard on the kidneys, and so we want to, kind of keep a close eye on that and make sure that if the patient has any kidney function issues, that I'm not making something worse. So then there's alpha and beta blockers. So these help by, we are kind of talking before, diuretics help with that fluid load. So alpha and beta blockers, we talked about that fight or flight response. And right now you may be in the flight, like I want to run away from all of these medications. So your alpha and beta may be stimulated right now. These are alpha and beta are cells that are in your body that kind of respond to different stimuli and kind of like get your body responding to things when it needs to. And one of the ways that they respond is that they, like when you're sitting there and you're in a stressful situation, they vasoconstrict or increase your blood pressure to help you fight in a situation that you need to fight, or they help you to run when you need to run. And so if we give medications that block that fight, go constriction, then that's going to help to decrease your blood pressure. So they allow blood vessels as a whole to be more open and relaxed, which allows for better flow of blood. And so alpha as a whole, they relax blood vessels and they lower your blood pressure. Beta works a little differently in the sense that it relaxes the blood vessels, which lowers your blood pressure. But they also, by blocking that fight or flight, they also lower your heart rate. And this just has to do with where the beta cells are located. So alpha, just blood vessels, lowers your blood pressure. Beta lowers your blood pressure and your heart rate. So let's talk about those alpha blockers. There's alpha 1 agonists and alpha 2 antagonists. And don't get too caught up in the agonist antagonist. Just know both of these are going to block that, vasoconstriction, that really narrow constricted blood vessel so that you can have better blood flow. So alpha 1 agonists are going to be like clonidine. And I have the 3 Ds to remember kind of for side effects. It makes you dizzy, like orthostatic hypotension. It makes you drowsy, and it makes your mouth dry. So a lot of times we tell them to kind of suck on a lozenge or chew on some gum to help with that dryness. And we're going to want to check their blood pressure prior. You're going to see here the other type of alpha, and alpha 2, the doxazosin. This is very similar. The only difference is it doesn't have that dry mouth side effect the same. So we're really just worried about dizzy and drowsy. So if you had to start, and you, of course, you want to check your blood pressure before, because these are both going to affect the blood pressure. But look at this. So like these are pretty much the same. So aside from like kind of learning the names, so for alpha blockers, the big things is they make you dizzy and drowsy. And for the clonidine, you want to put some sort of, something for their dry mouth. And so that's the only thing that you really need to differentiate these. So instead of thinking of them as one big scary, like a bunch of different things, like, these are very similar. You're just kind of looking at what are these differences between them. So let's go to beta blockers. So all beta blockers end in LOL. And for all beta blockers, we want to use caution in diabetics. And this is because normally, like when you have low blood glucose, your body responds in a way where your heart rate, increases. And your heart rate increases because it's trying to pretty much, produce, like get your heart to pump more blood out, to pump more sugar out, to get more out to your cells because your blood sugar is low. So your body naturally responds to a low blood glucose with a high heart rate. But if I'm a diabetic, and I'm on a beta blocker, my heart rate's going to already be lower. So even if, let's say that I'm a diabetic and I'm taking a beta blocker and my blood sugar's low, normally my heart rate would have gone up when my blood sugar is low. But if I'm on a beta blocker, that's going to literally block my normal response, that fight or flight, like, hey, pump faster. And so I might not know that, my blood sugar's low. I'm not going to be able to sense that same reaction. Sorry, my cat's talking. So for these patients, like any type of beta blocker, I always want to use caution and just realize that, I'm going to need to check blood glucoses more often, and I'm going to need to keep a closer eye on them when it comes to those symptoms of hypoglycemia and keeping a close eye on those. Um, for all patients on all types of beta blockers, every single one, I'm going to need to check their blood pressure and heart rate prior. And every single one of them, just like every medication here, all of them, I need to tell them to change position slowly because that orthostatic hypotension. So, I always think of this like I choose you, like if you're a Pokemon fan. For beta blockers, there's two types. So keep in mind something about beta blockers. Sorry, my cat's rubbing her face on my screen. So for beta blockers, there's, you have cells in both your heart and your lungs, and because of that, we can have selective and non-selective beta blockers. And all this really means is that like what cells are they really focused on? So there's what's called cardioselective, which means these are really focused on just the cells that work in the heart. Which is really good. If I have a problem where I'm having a problem with my blood pressure, things like that, like I want it to be really focused. So that's what atenolol and metoprolol are. But there's also what's called non-cardioselective. And the thing to consider is that it affects the cells that are in the heart, but it blocks the cells that are in the lungs. And by blocking the beta cells that are in the lungs, it actually causes a constriction or a closing in the lungs. I know it's kind of opposite. It's strange that it opens up the blood vessels, but somehow closes the lungs. But this is the way it works. It closes or can cause like a bronchospasm for a patient, that has asthma or COPD. That's going to be really dangerous. So as a whole, if I have like any sort of constrictive respiratory disease, COPD, asthma, long-term smokers, things like that are going to have a lot of problems with their lungs, we're going to move towards doing the cardioselective because I don't want to be messing with their lungs. They got enough issues with their lungs. Now, again, you're not ever prescribing these, but it's important to know that, like, if you see a patient that's on a cardioselective like propranolol and they have a respiratory issue, it might be something you want to bring up with the doctor and maybe consider if that's appropriate for them because it could lead to a dangerous outcome. So there's also vasodilators. And what vasodilators do is they allow blood vessels to be generally more open and relaxed. So, what we've been talking about vasoconstriction all this time. So vasodilation is the opposite of constriction. So what it does, it works on the muscles outside. And yes, your blood vessels have muscles because they're awesome. Your blood vessels, pretty much forces the muscles around to relax. So everything opens up. This allows for better blood flow because everything's open. So it allows for less resistance and everything's nice and open. But when you think vasodilation, think blood pooling. And this will make a lot more sense. But think of it this way, like if I'm sitting on an airplane with my feet dangling for hours, they always say you're at risk for blood clots. And that's because blood is pooling in your legs because there's more resistance that that your legs have to overcome to push that blood back up to your heart. So it kind of sometimes just pools down there. And that's what happens with vasodilation. Having open and relaxed blood vessels sounds great, but we need a little bit of squeeze so that we can get that blood back where it's supposed to be. We need a little bit of squeeze to get blood to our brain, to get blood, back up to our heart from our feet. And so we need some resistance, and vasodilators kind of take that away. They take away that little bit of squeeze. And so it's not that blood has no squeeze and it can't move at all, but it definitely makes it harder. And so as a whole, kind of think of blood pooling. And so, when we're talking about these, that's one of the things when you're looking at some of the side effects. So there's nitrates like nitroglycerin and things like that, isosorbide, mononitrate, and dinitrate. There's also hydralazine, and hydralazine is really commonly given by mouth or IV when patients are in the hospital. So with both of these, we want to check blood pressure prior and change position slowly. Once again, if I'm given a medication for blood pressure, got to check it before. And then I'm always going to tell every patient to change position slowly because all of these can cause that orthostasis. The real difference between these is with the nitrates, they cause a lot more of that vasodilation effect. They're a lot more potent. And so they can have flushing and headache. And this just has to do with the fact that flushing happens because of the pooling of the blood, like in the face and things like that, because it doesn't have that same squeeze to get places. And same with the headache. Headaches happen because of vasodilation. And the other thing to keep in mind with nitrates is we don't want to take these with erectile dysfunction drugs. And those are the ones that end in fill, like sildenafil, and things like that, because these are the medications that are really going to cause a lot of issue because they do the exact same thing. So if you kind of notice, like with a lot of these cardiac medications, we're trying to warn you, like you're not going to be able to memorize every single possible interaction between these meds, but we're trying to show you what the like when patients are given blood pressure meds, they're commonly given them together because one medication usually doesn't do the trick. And so we're trying to, like show you and kind of warn you, like, hey, commonly patients that have this disorder also have this disorder, and they're going to be taking these meds and they interact. And that's why, like, the things that I'm bringing up, like, it's very common for older people to have high blood pressure. It's also very common for older people to take erectile dysfunction drugs. So knowing some of these really common but possibly deadly things is really important. And so erectile dysfunction drugs are vasodilators too. So if patients take an erectile dysfunction drug that is a vasodilator plus another vasodilator, they can have a severe vasodilation and really have no squeeze to get their blood flowing. So there's also ACEs and ARBs, and this is ACE inhibitors, which is what do you call it? Angiotensin converting enzyme inhibitors, and ARBs, which are angiotensin receptor blockers. Excuse me, those are the S. And so these help in two ways. They allow blood vessels to be more open and relaxed, which again allows for better blood flow. But they also help to reverse that RAS system, that renin angiotensin aldosterone system. And what that is pretty much when your kidneys aren't getting enough blood flow, the RAS gets stimulated and pretty much sets this chain of events that tells your body, like, hey, I'm not getting enough blood flow. I need more sodium. I need more water. And it just keeps doing this over and over. And at first, it might help, but after a while, it actually makes it worse. And you have more sodium, you have more water, and it's really not helping at all. And so, at the end of the day, as much as your body's trying to help, the system doesn't really help. And so, these ACE inhibitors or these ARBs can help block that system. Something to keep in mind is when you have less sodium, or if I'm letting go of more sodium, which I'm doing with these medications, I'm going to have more potassium, and we're going to talk about that. And so I have kind of my mnemonics that ACE inhibitors, they all of them have pril in the name, Pril. So prils make your blood pressure chill. Ah, you like it? And then ARBs are sartans, and the sartans get your cough from startans. And so, yeah, I always love my little mnemonics. They're so fun. They help me to remember them because trust me, teaching these in the beginning was a challenge because I was like, wait, which one is this? Because sometimes the level that when you're not seeing these medications every day, definitely it changes your perspective. So anyway, so ACE inhibitors and ARBs, these are both the same, except pretty much ACE inhibitors causes a cough and ARBs do not. And they also take a little bit longer to get started working, like they don't work immediately as fast. So if patients are on an ACE inhibitor and they start complaining of a dry cough, we can switch them over to the angiotensin receptor blockers. But because as a whole, like why we would do that, you would think, oh, it's just a cough. What's the big deal? It's harmless, and it is. But a lot of times, people are going to use any reason not to take these medications. So we want to encourage compliance. So one way we can do that is if they're complaining of a symptom, we can change them over to something that's going to help with that compliance. So general teaching, because again, there's no difference between ACEs and ARBs aside from the fact that one causes the cough and one doesn't, and that the ARBs take a little bit longer. The general teaching for both of these is that it's hard on the kidneys. So we're going to need to check kidney function and make sure that the patient's kidney function is doing okay. We're going to check their blood pressure prior to taking the medication. And again, change position slowly, as with all of them. And the general teaching also includes that this medication increases potassium. So we want to avoid things that also increase potassium and potassium-rich foods. And remember, what else do we talk about that increases your potassium? Wasn't there another drug? Yeah, we're going to talk about that here soon. This is what I'm talking about, how we're looking at which of these interact. So if patients can be on an ACE and an ARB as well as a potassium-sparing diuretic, which happens all the time, we want, not that they're on the same one, but if patients could possibly be prescribed both of these, as the nurse, I need to be be aware that, hey, both of these things raise potassium. And do I want my potassium raised? No, 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 because that is how we do lethal injection. And no one wants a lethal injection, what do you call it, from their blood pressure medicine. Last but not least, there's calcium channel blockers. I know you didn't believe I would ever get to the end. And these help by relaxing blood vessels and allowing them to open up and have better blood flow. Are you seeing a pattern here? Almost all of these help open up the blood flow vessels, allow for better blood flow. They also have a way they can help the heart. They can increase electrical activity and excitement of the heart, which, I mean, I don't know why you would want to do that. But if you're not a big fan of dysrhythmias, you can also use calcium channel blockers for those too. There's two types. There's one type that's used for the dysrhythmias, and there's one type that's used for hypertension. The type that we're going to talk about today, because today we're talking about hypertension, is going to be amlodipine. And this is the type that is going to be used primarily for blood pressure. It's the most common medication given for blood pressure in that class. And when, again, we want to tell patients what? Check your blood pressure, and you'll probably want to check your pulse. These have a potential to lower your pulse, so you probably want to check that before as well. They work mostly on the blood vessels, but because of the class that they're in, I'm always extra careful, and I usually check prior. Also telling them to change position slowly, as always. That hasn't changed. Something that's different about this is it can cause gingival hyperplasia, and it can cause a lot of dental issues. So we want to encourage really good dental hygiene. And then also, it is a not potent, but it's a peripheral vasodilator. So in other words, in my tiny little vessels, it can cause them to open up and, vasodilate, which is part of how it works. But it can also lead to some swelling. Because remember, if you think vasodilator, you think pooling of blood. So just some things to keep in mind. So let's bring up this potassium thing one more time just to kind of sum it all together. Remember, we want to avoid potassium-rich foods in potassium-sparing diuretics and ACEs and ARBs, because remember, in those, they already have a lot of potassium. I know this is going to seem kind of off topic that I'm going to potassium-rich foods, but I'm using this to sum up just because I didn't really talk about the potassium issue. So to kind of back up, if you remember, potassium is a problem if it's too low or too high. So anyway, going back in. So we're going to avoid potassium-rich foods for potassium-sparing diuretics and ACEs and ARBs. And here's like a list of a bunch of foods like bananas, leafy greens, peaches, some tomatoes, some fish, some meats and things like that as well. And so there's like a lot of fruits and vegetables there. So, really staying away from those. Especially what do you call it? Everyone thinks of bananas and potassium and things like that. Anyway, these are just some common foods that patients might need to be taught, like, hey, you want to avoid doing that. And if patients already eat high levels of these foods, like, a lot of times they don't necessarily need to change what they're eating. It's not time to start a new healthy habit. And a lot of times when patients get started on blood pressure medicine, they're like, oh my God, I got to eat healthy. And they'll start changing the way that they diet, which we told them to, but we need to make sure that they're aware that these are some foods that they might need to be careful around. The other thing that I like to bring up is that, a lot of these patients are on a low sodium diet. And so what are they given instead of salt on their tray? They're given a salt substitute. And those are actually high in potassium. So it's kind of a go figure. It's like, here, you need the salt substitute, but also if you take it with your medication, it may kill you. And so kind of the not fun thing. But at the end of the day, we want to be really careful, make sure that they know that salt substitutes have potassium in them. That's what actually replaces the salt is the potassium. And so, at the end of the day, this can be really dangerous for patients. So they're going to need to watch their intake of that. And so on the opposite end of the spectrum, we want to encourage these kind of foods in patients that are on loop or thiazide diuretics because they're going to be low in potassium. So for these patients, this is good, good, I can talk. And so this is all good stuff. And so we're going to encourage these foods and make sure they're aware of these, that they may need to increase their intake of these foods. And so as a whole, potassium sparing, ACEs and ARBs, avoid these things, watch out for salt substitutes. Loop or thiazide diuretics, it's good stuff. Eat more of them. You're going to need them to replace that potassium. And a lot of patients that are on the loop and thiazide diuretics, they're going to end up on potassium supplements, because they're going to really need that, maybe on top of the food that they're eating. But understanding what foods are going to affect their medications is super important, as these can be life or death. So hopefully, I know that wasn't short, simple, sweet to the point, but hopefully it was more simple than your theory lecture, especially if you had me. So hopefully that helped to simplify some things and kind of help you to better understand the awesomeness that is cardiac medications. And I should say just hypertension medication. There's more to come. Don't worry. You can sit on the edge of your seat and wait until the next video gets released. See you next time. Hope you're staying warm.